Kia ora tātou, no mai haere mai to our Goodfellow webinar on acne, the impact on quality of life and best practice management. My name is Katie McCulloch. I'm a nurse practitioner that works for the Goodfellow unit and in primary healthcare in South Auckland. And tonight we're going to be hearing from Dr. Peggy Chen. Peggy's a vocationally registered specialist dermatologist and an American Mohs College certified Mohs micrographic surgeon based in New Plymouth. On top of her clinical work, Peggy is an associate editor of the Australasian Journal of Dermatology, a member of the Ministry of Health Melanoma Standards Working Group, and a member of the New Zealand Advanced Dermatology Training Committee. This webinar is kindly supported by La Roche-Posay. La Roche-Posay is a dermaceutic range with many products for sensitive skin pathologies like acne, rosacea, dry skin, and eczema-prone skin. They are recommended by dermatologists worldwide. I'm now going to hand over to Peggy.
Thank you very much, Katie, for that introduction, and good evening, everybody. Thank you for choosing your Tuesday evenings to spend on listening to Acne Vulgaris and its impact on quality of life. And as Katie mentioned, this talk is sponsored by La Roche-Posay. This evening, we will be looking at the various aspects of acne. And I'm sure many of you, if not all of you, have seen different aspects and clinical presentations of acne. It affects the young, the old, and even celebrities can't escape this. Why do we need to know about acne? Well, because it's very common. More importantly, it can be easily and effectively treated. On the flip side, if left untreated, it can pose significant negative psychological and social impact. In a nutshell, acne is a highly prevalent inflammatory skin condition that is characterized by inflammation of the pilosebaceous unit, as signified by this photo and diagram here. The statistics from the United States shows that each year, 40 to 50 million individuals are affected. This leads to an estimated related healthcare cost of $2.5 billion US. Its peak incidence is around the adolescent year, with 85% of young people between the ages of 12 to 24 years are affected. What may be slightly more surprising is how prevalent it is in the older age group. 35% of women and 20% of men are affected in their 30s, while 26% of women and 12% of men exhibit signs of acne in their 40s. There has been no specific racial or gender predilection. However, individuals with underlying endocrine disorders are at increased risk. They include XXY karyotype, polycystic ovarian syndrome, hyperandrogenism, and hypercortisolism. The pathogenesis of acne is multifactorial. While the role of genetic predisposition is uncertain, the number of sebaceous gland and the size of sebaceous gland is certainly inherited. The concordance rate of prevalence and severity of acne is extremely high amongst identical twins. The etiology of acne is firstly heralded by an increase in androgen. This leads to an enlargement in the sebaceous glands, and thus with increased sebum production, they form follicular keratinization. The follicular keratinization leads to follicular plugging, and therefore we have formation of comedones. That is characterized by retention and accumulation of corneal sites, as demonstrated in the photo on your right. The formation of comedone incites inflammatory cells, and it recruits CD4+ cells, interleukin-1, and neutrophils. This gives rise to the clinical picture of inflammatory papules and pustules as demonstrated on the photo. the last decade or so, the role of microbiome in the etiology of acne has been gaining traction. C. acnes, or previously known as Propionibacterium acnes, which is shortened to P. acnes, it's present in low numbers on the skin surface. However, it is the dominant resident bacteria in the pilosebaceous unit. And the other dominant bacteria is Staph epidermidis. C. acnes is a gram-positive rod. As mentioned, it resides in the sebaceous follicle. It fluoresces under wood's lamp. It has been long believed that the inflammatory component of acne is a result of overproliferation of C. acnes. However, more recently, studies have compared healthy individual skin to individual skin with acne. And what they've found is that the number of C. acnes comparing between the two is actually very similar. The differences they found is in the diagram on your right. So it's actually the makeup of C. acnes phyllotypes. So in healthy individuals, there are more phyllotypes of C. acnes found compared to individuals with acne. Therefore, it is postulated that dysbiosis, or the concept of an imbalance of microbiome, leads to further inflammation. In addition, the gut microbiome also has a role to play in the etiology of acne. A decrease in gut flora diversity leads to an increase in intestinal permeability and therefore causes a release of more pro-inflammatory mediators. I would like to draw your attention to this part of the diagram here. We have the burger and the ice cream and how that feeds into the loop. So this is relevant to my next slide, as diet has always been controversial in the topic of etiology of acne. And I believe most of you will be asked the questions in your clinical practice from your patients: what should I eat? Is it something that I'm eating that's causing my acne or leading to worsening of my acne? So for many, many years, we have not had convincing evidence to support which diet is better or worse for acne. However, because of the recent light that's been shed on the gut microbiome, we understand that a typical Western diet, a diet that's high in refined carbohydrate or high in glycemic load, can cause a decrease in gut flora diversity, therefore leads to an increase in pro-inflammatory mediators and causing more inflammatory acne. As doctors, we are all very good at prescribing medications. And we do need to think about and know that some of the medications that we prescribe can cause a worsening of or actually be the cause of patients' acne. And it is also very important to take a history from the patient to make sure they are not using anabolic steroids recreationally. So we'll quickly go through some of the clinical features of acne. First, as mentioned before, acne is present because of increased sebum production and the follicular plugging. So acne usually happens where the sebaceous glands are mostly densely populated, and that is on the face, upper chest, and back. On your right-hand side, we have two photos demonstrating the open and the closed comedones. So open comedones, also known as blackheads, and closed comedones known as whiteheads. Once the acne becomes more inflammatory because of the inflammatory cell involvement, then we can have clinical lesions of inflammatory papules, pustules, and on the bottom here we have nodules and cysts. Acne can also give rise to secondary lesions such as acne excoriae or excoriations, erythematous macules, and pigmented macules. Pigmented macules are more commonly found in skin phototype 4 and 5. And down on the right bottom hand corner photo here, we can see ice pick scarring and box scarring. It is always very important to ensure that we have made the correct diagnosis. So quite often acne can be confused with other skin conditions such as rosacea, folliculitis, KP, or milia. Now, the very important thing to make a secure diagnosis of acne is to look out for the presence of comedones. So comedones as well as pustules and papules are needed for diagnosis of acne. If the patient does not have comedones clinically and only has pustules or papules, then acne is very unlikely. So in clinic, in day-to-day practice, we usually grade acne based on their severity. So we classify them into mild, moderate, and severe. Now, these classifications are taken from a dermatology textbook, Bologna, and I have to say the classification is rather arbitrary as it is based simply on lesion count. So mild disease is defined as less than 20 comedones or less than 15 inflammatory lesions or a total count of less than 30. Moderate disease is anywhere between mild and severe disease. So arbitrarily, it's been defined as a total lesion count between 30 to 125. Severe disease is defined as more than 5 cysts or have more than 125 total lesion count. And I will put scarring there as well, as this will dictate what treatment we use later on. So I want to draw your attention to the psychological and social impact of acne on patients, as this is a very important aspect and probably an aspect that we have not been recognizing or doing a good job in treating this aspect of patients' acne. So globally, acne is the second most disabling skin disease after eczema. The impact of acne on the quality of life of teenagers and adults has been documented as comparable to other chronic illnesses, such as arthritis, diabetes, asthma, and epilepsy. Lots of studies have been done to assess the impact of acne on patients' quality of life and their self-esteem. I would like to draw your attention to this paper published in BMJ in February this year. It is a systematic review looking at views and experiences of people with acne vulgaris and healthcare professionals about treatment. And disappointingly, the paper have concluded that acne has quite often been perceived by the healthcare professionals as a short-term problem. And patients report that acne has quite often been trivialized by their healthcare professionals and therefore lead to a delay in diagnosis, delay in treatment, or an inadequacy in treatment. So we can all do better in this area. Now, this is a questionnaire basically assessing the acne impact on people's psychological and social well-being. This is a questionnaire published and validated by the European Academy of Dermatology and Venereology. And it is a specific questionnaire designed for patients with acne. It is obviously similar to, I'm sure all of you will know about the quality of life DLQI score for various chronic illnesses, but this one is specific for acne, and I would encourage people to get a hold of a copy of this and use this in their clinical day-to-day practice, and so that we can track patient score along their acne journey. So what should we do in the initial assessment? First of all, we obviously need to make sure we've made a secure diagnosis of acne. Then we need to classify their acne based on their severity category into mild, moderate, or severe, as mentioned before. Particularly in women, most of the women with acne do not have a hormonal imbalance. However, we want to make sure that we do look out for signs of hyperandrogenism, such as hirsutism, obesity, and asked about their menstrual irregularity to consider, do we need to screen for this patient for polycystic ovarian syndrome? We want to assess the emotional and social impact of acne on the patient sitting in front of you. I want to draw your attention to this salient point. It does not necessarily correlate with the objective severity. Mild acne can have as profound effect as severe acne on that patient. And importantly, as alluded to, the emotional state of the patient can influence the choice of therapy. Lastly, we also want to consider any aggravating factors or patient occupation and leisure activity that could be contributing to their acne. And I think what's very topical at the moment is the topic of mask wearing causing maskne. So therefore, we need to talk and discuss and give patients tools to help them deal with that. So now we will move on to treatment. So the treatment approach should be multifactorial, as the pathogenesis of acne is multifactorial. We want to target the sebum production. We want to do something about the alteration of the keratinization process. We can target the C. acnes and also the inflammatory pathways. The goals of our therapy is to resolve any existing lesions. We want to prevent any further scarring and also give patients the tool to cope with psychological distress resulting from their acne. So the basic principle of treatment is firstly asking them to avoid oil-based skincare products and cosmetics. So we want to find something that is light, that's not occlusive, that is water-based. And we also want to make sure that patients do not excessively wash their face, exfoliate their skin, or scrub their skin. I think quite commonly when patients have acne, because they can feel the lumps and therefore they want to exfoliate to make their skin smooth. But this will further promote inflammation. Therefore, definitely ask patient to avoid doing that. I have started recommending patients to take pro and prebiotics in my clinical practice, just because we want to make sure that patients' gut flora diversity is preserved. We want to make sure that patients have a good, well-balanced diet. So as mentioned before, we want to avoid a diet that is high in glycemic load or high in refined carbohydrate. Lastly, but very importantly, we need to encourage a regular sleeping pattern, which can be very difficult in teenagers. Here is a summary table of treatment options based on the treatment guidelines. They are separated into 3 groups. On the left-hand side, you can see the comedolytic, anti-inflammatory, or anti-androgen. So all these therapies target the different parts of the pathogenic process. And we will go through them more closely in my subsequent slides. So first of all, we will come to the first line topical option for mild acne, which I'm sure all of you will be familiar with, that is benzoyl peroxide. So benzoyl peroxide is metabolized in the epidermis to benzoic acid and free oxygen radicals. It has a bactericidal property. It disrupts the microbial cell membranes. More importantly, it also has anti-inflammatory and comedolytic activity. You can either use it alone or combine it with other topical options. This is standard of care for mild to moderate acne at a concentration of 5%. And you can find them in commercially available products such as Benzac and Clearasil Ultra Acne. It is important to warn patients that this may cause an irritant dermatitis. So the signs for irritant dermatitis is redness, scaling, burning, and itching. And we also need to, very importantly, warn the patients or their parents about the bleaching side effects so that they don't get a shock with their pillowcases. An alternative first-line option for mild acne is salicylic acid or its derivative lipohydroxy acid. So salicylic acid possesses a curalytic and comedolytic activity. It breaks down the follicular plugging and promotes the desquamation of follicular epithelium. Therefore, it is very good for comedonal acne. Examples of commercially available products include Neutrogena Clean and Clear. In addition, lipohydroxy acid is a derivative of salicylic acid. It has a better tolerance profile compared to salicylic acid. It was first developed in the 1980s, and it has less skin penetration, and it is retained in the stratum corneum. Therefore, it has a larger reservoir effect. So an example of this is the Effaclar jaw. There has been studies done looking at the comparison of efficacy between 5% benzoyl peroxide versus 0.3% of lipohydroxy acid. And the effect or the efficacy is very, very comparable in terms of its reduction in inflammatory lesions. Second-line topical options for mild acne is the derivative of vitamin A or retinoids. So the retinoids that's available in New Zealand are either adapalene or tretinoin, or the trade names are Differin or Retrieve. So the derivatives of vitamin A act to normalize desquamation by reducing keratinocytes proliferation and promoting differentiation. Therefore, it is also very good for comedonal acne. We need to be very aware that the patients, or particularly female patients that we are prescribing these to, they are not planning on to become pregnant or not already pregnant or are breastfeeding. If the response to topical adapalene or tretinoin is not adequate after 6 weeks, then we need to consider to change to a topical combination treatment. So what are the combination treatment options? So on your left-hand side, we can combine the benzoyl peroxide with adapalene or benzoyl peroxide with lipohydroxy acid. So this is useful if the acne we have is mainly comedonal. If you have a combination of comedonal and inflammatory lesions, then the recommendation is to use clindamycin plus benzoyl peroxide. And this is trade name is Duac. But I believe Duac is not available at the moment in New Zealand due to a supply chain issue, because I tried to prescribe somebody Duac just last week and had a phone call from the pharmacist to say that that's not currently available. So when it becomes available, certainly this is a good option for both comedonal and inflammatory mild acne. However, we want to make sure that we do assess the patient, as if the acne, as soon as it becomes non-inflammatory, we want to try and stop the clindamycin component and just use either topical retinoid or just the benzoyl peroxide or the lipohydroxy acid as a maintenance therapy, because we don't want to encourage that antibiotic resistance. So for moderate to severe acne, oral antibiotics is a very good choice. And in terms of the antibiotics, we want to use tetracycline over macrolide, because tetracycline is certainly being shown to be much more effective than macrolide in terms of treating acne. However, we all know that tetracycline cannot be used when the patient is pregnant or for patients that's younger than the age of 8. So in those cases, we want to use a macrolide such as erythromycin. When we prescribe oral treatment, we should always prescribe that with a combination of a topical product, either a single agent or a topical combination agent. So as alluded to before, if the acne is predominantly comedonal, we want to use either benzoyl peroxide or retinoid or lipohydroxy acid. If it's more inflammatory, then you want to use the topical clindamycin. So after we prescribe oral antibiotics, it's very important that we do review patients. We don't just give them 3 months of oral antibiotics and say, see you later. We want to make sure that we know how they're going after 6 to 8 weeks. If the treatment is, or if the treatment effect or therapeutic effect is insufficient after 6 to 8 weeks, then we should really consider switching patients to oral isotretinoin. If we can already see signs of scarring, we should also consider switching them to oral isotretinoin. And very importantly, we need to monitor patients' emotional status. If there is significant emotional impact, we also want to make sure we start isotretinoin early. Now, which I will come to, because there has been a lot of papers about isotretinoin causing depression and anxiety, so I will address that. So before we go to oral isotretinoin, I just want to slip in the combined oral contraceptive pill. So COCP is an alternative to antibiotics in teenage girls and women with moderate to severe acne. It is important to counsel the patient before you start them on COCP for acne purposes that the effect is going to be very slow. And it may not even be apparent for at least 3 months. So we really need to give the COCP a 6 months trial to see if there's any benefit. So the COCP that most likely to improve acne contains cyproterone. So the funded option in New Zealand is Jeanette. I believe Yes and Yasmin was funded, but that's now no longer funded anymore. Otherwise, that's also an alternative option. Now, spironolactone is very useful in women who has underlying hyperandrogenism, and quite often I use that for women with adult onset hormonally driven acne. Usually, just like the COCP, spironolactone can be quite slow. So also 6 months, 3 to 6 months trial is needed to see an apparent effect. And the dosage is around 50 to 100 milligrams once a day. And this is also contraindicated in pregnancy. So now we come to oral isotretinoin. Now, oral isotretinoin is the treatment of choice for acne when acne is severe, is cystic, or is scarring, or the patients are suffering from significant psychological impact from their acne. Now, in the UK, usually they prescribe it with a cumulative dose in mind. So the cumulative dose is quoted in the literature to be 120 to 150 milligrams per kilogram over the course of treatment. So that's your total dosage that you will have. I have to say that in New Zealand and Australia, we don't quite follow the cumulative dose regimen. So usually we just base it on patients' clinical response. So you start patients on oral isotretinoin and you aim for clearance. Once they've achieved clearance, then you keep them on it for another 3 months. Then we can start dose reduction slowly. And then that usually prevents relapses. So importantly, I tell patients that the cumulative dosage of isotretinoin in your system is inversely proportional to your relapse rate. Therefore, if you have more, then you're less likely to have a relapse, to be needing a second course of oral isotretinoin. So for your female patients, we have to make sure that we counsel them that during the course of their treatment, they cannot become pregnant. And therefore, we advise double form of contraception. And before we start them on isotretinoin, we always require a negative pregnancy test. Now, when I was a registrar, we used to have to ask patients to sign the consent. And in fact, that's still the case in the UK. But certainly now, we don't obtain written consent anymore in New Zealand. We just document that clearly in the notes that we have had a discussion, and we start the patient only after they've had a negative pregnancy test. Now, there are a few adverse effects associated with oral isotretinoin, and most of the adverse effects with oral isotretinoin is dose related. So the commonest side effects is dryness. So dryness in the skin, dryness in the mucous membrane. They can have increased UV sensitivity. And because of the dryness, quite often people's eczema can flare. In females, there's been documentation of myalgia and joint stiffness. It's more common in females compared to males. Less commonly, people can suffer from paronychia, dyslipidemia, headache, hair loss. Now, impaired night vision certainly is something that we have to discuss with the patient, particularly if patient does a lot of night driving, or if they are considering to become a pilot, or if they are a pilot. So certainly if they are considering to become a pilot, my advice is not to start them on isotretinoin. If they are a pilot already, then we don't start them on isotretinoin. Even though in the literature, impaired night vision is reversible after we stop isotretinoin, I would still be cautious about that. Now, in terms of the mood changes and mood disturbances that I have alluded to before. So certainly depression, anxiety is not an absolute contraindication to starting isotretinoin. So certainly we always have to work together with their principal psychiatrist or psychologist. We certainly write a lot of letters to the patient and to their psychiatrist just to make sure that everybody knows what we are doing. And so their mood and their medication for their psychological condition can be appropriately monitored. And in fact, in my clinical practice and also in a lot of papers, it's been documented that after patients have been started on isotretinoin, people's depression actually improve. So certainly a documented depression or anxiety disorders is not an absolute contraindication in starting isotretinoin. And I'm sure all of you have lots of questions about this, and I'm happy to answer them at the end. Now, what happens if patients cannot tolerate any medical treatment? Then certainly we have alternative surgical and physical treatments available to offer them. So for comedonal acne, we can do comedone extraction. PDT is also an alternative in treating moderate acne. Or lasers can target the scar as well as inflammatory lesions. For big cysts and nodules, certainly we can inject intralesional corticosteroid, or chemical peels can be effective for mild acne. What about the role of adjunctive therapy? So adjunctive therapy is very important, and it's quite often neglected in clinical practice because we're short of time. We don't have, we already discussed so many things about our prescribed medications. However, it actually is very complementary to what we prescribe in clinic to patients. So as talked about, benzoyl peroxide can cause irritant contact dermatitis. Retinoid can also cause irritation. Oral isotretinoin can cause dryness, increase photosensitivity. So we all need adjunctive skincare to address these issues arising from the medications that we've prescribed to patients. So skincare can improve the condition of the barrier function and in turn reduce the impact of inflammatory triggers. Skincare can also manage the skin dryness, and we all need good sunscreen in New Zealand, and this is certainly what I say in clinic to patients with acne. I say it doesn't matter if I'm giving you doxycycline or isotretinoin, you need to have good sun protection regardless, just because we live in New Zealand. So specifically, I just want to discuss some particular ingredient in some of the skin adjunctive therapy. So topical niacinamide or vitamin B3 has very good anti-inflammatory property. It inhibits mast cell histamine release and neutrophil chemotaxis. It also inhibits the secretion of inflammatory mediators. So in acne, it has been found to be used for its anti-inflammatory property and also decreases sebum production. It's found to be just as effective as 1% clindamycin in the treatment of acne. Obviously, this is not part of the talk, but additionally, it also can lighten pigmentation and has anti-aging properties. Zinc-based actives. So topical zinc has been widely accepted for its dermatological uses, particularly in its role in UV protection. In acne, in the paper published as shown in the slides, it also has an anti-acne properties, We don't completely understand how it works at this stage, but its anti-acne property is thought to work via both sebum control and also antibacterial pathways. There's been a question mark about whether zinc-based actives does increase the absorption of other actives, but there's yet to be more work done about that. So when you are seeing a patient with acne, when should you consider to refer to a dermatologist? Well, when your patients are not responding to simple topical treatment, when they have very resistant forms of acne, so back acne, buttock acne, or adult female hormonal-driven acne. So they're typically the patients that I mentioned about how spironolactone can be a useful option. So clinically, they have the nodules and cysts along the lower third of their face, and it's predominantly on the jawline. If they have any evidence of scarring, then treatment definitely should not be delayed. It should be started, and you can consider to refer to a dermatologist. So we all want to achieve the best outcomes for our patients in managing their acne. So we want to make sure we start acne treatment early to minimize any potential physical and emotional scarring. In terms of treatment selection, clearly we want to base it on their clinical classification of their severity and also based on their acne impacting on their social and psychological well-being. But other things to consider is we want to make the treatment convenient. Once daily treatment is always better than twice daily treatment because we know the adherence is never 100%. We want to think about patients' lifestyle. Would this treatment work better for their lifestyle? And we also want to think about the tolerability of the treatment that we've prescribed. We want to make sure that we outline the expectation of treatment. We discuss all the potential side effects. And importantly, we want to make sure that we ask patients not to squeeze their spots, because patients, when they can see something, they always want to squeeze it or feel it, and then they just constantly touch their face or touch their back, which is the worst thing they can do for their acne. We need to ask our patient to be patient. We need to say to them, everything with the skin takes time. Even when they're taking isotretinoin, it does not work for the first 6 weeks. And in fact, one very important thing that I didn't mention in my slides was that isotretinoin, when prescribed initially, it can cause a flare in acne. And those that are likely to flare are the ones that have lots and lots of nodules and microcomedones. And in that case, we need to make sure we give them something in the beginning of their treatment to make sure that their acne do not flare too much, so they lose faith in our management. So usually, isotretinoin should not be prescribed with doxycycline together because it causes an increase in their intracranial pressure. So usually I do combine it with either prednisone or a macrolide. If you are choosing to combine it with prednisone, then you do need to taper it over 4 to 6 weeks. So here is just a table about what's the proper facts about acne and what are some of the myths that's associated with acne. And I will leave you with that slide, and then I will open up for some questions.
Lovely. Thank you so much, Peggy. That was excellent. We do have quite a few questions coming in, so let's get started with them. In terms of long term, how long can you use a BPO and an LHA on a person's skin? Are there any concerns that you would have for those people who are suffering from persistent mild acne?
So with the lipohydroxy acid, it's certainly safe to use as a long-term maintenance therapy. With the benzoyl peroxide, however, it just depends on whether the patient is having any irritation from the actual treatment. I personally don't like to use long-term benzoyl peroxide. I usually, after I stop people on any oral treatment, I either ask them to use the lipohydroxy acid or I use a retinoid. But obviously that's not suitable when patients are, thinking about pregnancy and things.
Yeah. And do you ever use a topical retinoid and an oral? So with the isotretinoin and things like that, would you use the topical as well?
So not topical tretinoin or retinoids. So if the patient is already on isotretinoin, then I don't combine that with a topical retinoid because the patient's skin will be peeling and they probably won't thank you for that. Usually, if they still want a topical treatment, I will suggest the lipohydroxy acid or topical clindamycin if it's very inflammatory.
Okay. And what treatments would you recommend for scarring from acne?
If they only have scarring, so they don't have any active disease, I think the important thing is lots of time we see people with both scarring and active acne. Then usually I say we should target the active lesions first, the inflammatory lesions first. And then once that's all gone, then we'll target scarring. So if it's just scarring alone and there is no active acne lesions, then certainly chemical peel. It obviously depends on what type of scarring people have. So very, very mild scarring, derma needling can be helpful, mild chemical peeling. If it's deeper scarring, then resurfacing laser will be much more helpful.
Okay, cool, thank you. And starting on the antibiotics, what age is younger? You mentioned about the erythromycin. You can use erythromycin for younger patients.
Yes.
How young is young?
Yeah, so usually I would say probably you will start erythromycin for people who are around about 7 and 8, because certainly anybody that's younger than 8 years old will be contraindicated for tetracycline. But that's a guideline, but in my clinical practice, I probably would prescribe macrolide up to the age of 10, actually.
Right, okay. And in terms of doxycycline, how long can a patient who is quite happy on the doxycycline that's maintaining their skin stay on it for?
Yeah, so basically there is no guidelines to say how long the patient should be on doxycycline, particularly when it's used low dose for anti-inflammatory properties, not antibacterial properties. Personally, I don't let them stay on it for longer than 12 to 18 months because they certainly would disrupt their gut microbiome and it will increase our community resistance to antibiotics, which is not great practice.
And what dose of doxy and minomycin do you recommend to your patients?
So 50 to 100 once daily.
And would you monitor your LFTs if you were starting someone on doxycycline? And would you monitor renal function and potassium particularly if using spironolactone?
Yes, so that's very interesting. So for doxycycline, I probably would just do 6 monthly blood test monitoring, particularly if they're going to be on it for 18 months. In terms of spironolactone, I think as doctors, we get a bit anxious. So I certainly do monitor their renal function. So that will include potassium every 6 months though, so not very regularly. but there has been a paper published in JAMA Dermatology in 2016, looking at a large cohort of female patients on spironolactone for acne and whether they have had any significant side effects from their spironolactone in terms of their kidney and potassium. And the conclusion was, no, we don't need to monitor them. Yeah, so that's what that paper says. But I think just from my individual practice, I still monitor them 6 monthly.
What happens when you get a patient that frequently relapses after stopping isotretinoin? Can you keep going at a low dose, or is there a max length of time? As you were saying that, you don't really follow that cumulative, but how long is that max amount of time that we would tend to keep people on?
There's been a lot of long-term studies done looking at the long-term side effects or adverse effects related to long-term use of isotretinoin. And predominantly that's used for patients with rosacea or folliculitis. And certainly it's safe. And therefore, clinical practice, I have used low-dose isotretinoin for people with frequently relapsing acne. So they have come off 3 courses of isotretinoin, but 1 year later, their acne has flared up again. So usually 3 times a week or even twice a week dosing is just enough to stop that relapse and keep their skin completely acne free and with minimal side effects.
Okay, awesome. Do you have a standard dose with your isotretinoin? So obviously at that point you're going very low a couple of times a week, but what would you say your stages are? I had a patient that came from Australia that was on 40 milligrams or something like that for a long time.
That's right. So there certainly is different prescribing habits across different countries in the world. So in New Zealand, I think all of us are more sort of lower dose per day for longer duration. Whereas in Australia and probably the UK, we, when I was working there, certainly prescribed 60 milligrams a day, and just to get to that cumulative dose and then stop. So for me personally, it will be between 10 to 20. I very rarely go up to 30. So yeah, 10 to 20 will be my daily dose.
Okay. And I've just lost it. Sorry, there was a question about antibiotic resistance and clindamycin. So what are your thoughts around that in terms of trying to minimize that antibiotic resistance, but then there's clindamycin, which just showed that it has a high.
Yeah, that's right. So I think the way to go about that is in dermatology, we tend to use quite a lot of topical antibiotics, but actually topical antibiotics promotes antibiotic resistance more compared to oral antibiotics. So certainly I think if we can shorten the duration of topical clindamycin, then do it. And if patient is not responding, then we just switch to oral treatment. So yeah, that's my practice.
Okay. And in terms of different gel or cream, what is preferable for the face?
In terms of which preparation, the gel or the cream? Yeah, I prefer the cream actually, just because the feedback from my patient has been that the gel is quite sticky. Right. They don't really like it. So yeah, but in terms of actual absorption, I think there's minimal difference.
Okay. And in terms of the monitoring for Oratane and Accutane, I know that Health Pathways does sort of give us a good guideline on how often we should be monitoring, but what are the tests that you like to do for your patients before you start them, and how often are you keeping an eye on the monitoring?
Yeah, so basically to start off with, obviously for female is that negative pregnancy test, and then I would like to do a full blood count and their baseline lipids and liver function test. Okay. And then after that, if they are completely healthy, not on any other regular medications and don't really binge drink that much, I would then do another blood test in 8 weeks' time. And then it will be actually every 3 to 6 months.
And given that we have a really good resource in our long-acting reversible contraceptives now, are you still really pushing the double barrier or double contraceptive for isotretinoin?
In clinics, I'm not that strict, but certainly that's still in the guidelines. So that's why, I'm obliged to put it there.
There are a lot of questions about what prebiotic and probiotic do you use and recommend?
Right, yeah. So I don't sort of have any sort of brand preference. I certainly have seen quite a lot of people with inflammatory bowel disease or irritable bowel syndrome that also have been recommended to take pro and prebiotics. So I think the brand that I've just been recommending sort of informally, so this is obviously off-label and things, is the Inner Health Plus. So that's, quite a good option, and my patients have been finding that work quite well.
And they have a pre and pro option in that brand. Okay. And what about oral zinc? Does that help with acne? Just talking about supplements and things like that.
Yeah, so oral zinc hasn't been documented to show an effect in acne itself. However, oral zinc has been shown to have an effect in hidradenitis suppurativa. So I don't know whether the effect has not been shown because acne is such a sort of multifactorial problem. Because if we think about it, hidradenitis suppurativa and acne both are follicular inflammatory conditions. So I can't say there's evidence, but I can say there is evidence for another condition.
And in steroid-dependent patients, where steroids are completely unavoidable, they can often suffer from severe acne on the back and things like that. How would you manage something like that?
Then I think that's tricky because steroid is unavoidable. So certainly I usually then just give them isotretinoin, even though they're not severe and there's no scarring. But back acne is very resistant. And then if the patient needs to continually be on steroids, then
okay. And in terms of clinically differentiating between acne vulgaris and rosacea, how do you go about that?
So it's tricky, but the key is in comedones.
Okay.
So if there is only papules and pustules, then it's rosacea.
Okay.
If you've got comedones, then it's not rosacea, then it's acne. And then obviously you can look for other symptoms like flushing and telangiectasia with rosacea.
Okay. And can you ever have both conditions at the same time, which will make it very hard to differentiate?
Yeah, absolutely. I've certainly diagnosed both conditions. And people can have acne for a long time, and then all of a sudden they have rosacea on top of their acne.
Okay. And in terms of when people they've got a really good result from their treatment, and you're looking at finishing off whatever interventions that you've given your patients, what do you recommend is the best preventative treatment to maintain?
So in terms of maintenance, then certainly topical treatment is the treatment of choice, and I would suggest the lipohydroxy acid. If patients are starting to have comedones again, then I will give them the topical adapalene to use as on an as required basis.
And in terms of just going back to the steroid, because I know that I mentioned someone who's on prolonged steroid use gets acne, but when would you introduce a steroid to support acne management?
Correct. So if we are dealing with acne fulminans, which I didn't mention about that entity in my talk. So if patient has acne fulminans, then definitely we need to start steroid with very low dose of isotretinoin.
Right.
So that's the first instance. The second instance will be if you're starting a patient on isotretinoin and clinically they have a lot of nodules and microcomedones, then that's a sign that when you start them on isotretinoin, they will have a huge flare. So we need to cover with either steroid or macrolide.
Right. And how long do you do that concurrent therapy for?
So for acne fulminans can be for quite a long time actually. So sometimes can be 2 to 3 months. For just to prevent that flare, usually 6 weeks.
Okay. And what sort of doses are you using when you're introducing this?
Yeah, so acne fulminans is 40 milligrams to start off with, actually. Yeah. Not to prevent the flare. So to prevent the flare, usually start them just on 25 milligrams.
Okay, that's really interesting. Thank you. And back on isotretinoin, it's the big hot topic of the night. If we find any elevation, even if it's just a mild one, in the liver function tests of our patients on the first follow-up test at that 8-week mark when we've started them on it, but the patient's doing really well, how often would you consider monitoring and when would you consider stopping? And are there any other reasons that you would stop isotretinoin?
So with isotretinoin, with the liver function test, if it's a mild elevation, I probably wouldn't really mind that, and I wouldn't keep testing for it. So I would just organize another repeat in 8 weeks' time. Obviously, with severe elevation, as in if the ALT has tripled, then certainly I will get a repeat in a week, and just to see was there any other reason for that tripling in the ALT. And if that stays elevated, then I'll do a dose reduction first before I completely stop.
Right.
Because it is very, very rare.
Yeah.
The other very rare thing with isotretinoin is an increase in the triglycerides.
Right.
That's why it's always very important to get that baseline triglyceride before you start.
Okay.
Because then is if you have an elevation in triglyceride, then very rarely people can end up with pancreatitis.
Right. Oh, wow. Okay. And are there, apart from the triglyceride elevation and the liver function elevation, are there any other things that would make you go, okay, we need to stop? I mean, obviously, if it was a severe drop in mood or anything like that, but any physical symptoms that you would be concerned about?
The only other thing is I have mentioned about the myalgia and things. So certainly if people report severe myalgia, I will be doing a CK just to make sure. And if the CK is very high, I will be considering stopping.
Okay. Lots of patients have quite a bit of anxiety around intralesional steroids. What are your thoughts on that?
Yeah, so I personally don't do a lot of intralesional steroid injection because isotretinoin works so well.
Yeah.
So unless they are very, very, big resistant cysts, I probably also personally wouldn't be injecting too often.
Okay. And I guess that would be a specialist sort of. If you're considering doing something like that, you'd probably want a specialist review of the skin anyway.
That's right. Yeah.
In terms of, back onto the supplements again, in terms of B3 and oral zinc and oral B3 and those sorts of things, would you recommend those for helping to manage acne?
So the B3 evidence for acne management is more topical.
Yeah.
Now, I recommend a lot of oral nicotinamide for my patients because I have a large cohort of patients with skin cancers. So certainly oral nicotinamide at a dose of 500 milligrams twice a day has been shown to reduce the development of SCC.
Okay.
So that's where I've been recommending patients to take oral vitamin B3.
But not particularly for...
Not for acne, no.
And in terms of the oral zinc?
Yeah. So for oral zinc, I don't routinely recommend them, but if they also have signs of early onset of hidradenitis suppurativa, so that's a lot of inflammatory papules in the skin flexures, I would.
Okay. And do you have any recommendations for sunscreens as we move into summer, very important, that don't exacerbate acne that we could recommend for our patients?
Absolutely. So I personally do recommend the La Roche-Posay Invisible Fluid, the SPF 50 plus, because it's a water-based, it's not oil-based, and so it's not occlusive. And when patients are wearing the sunscreen, they don't feel like they are wearing sunscreen, and it certainly is not comedogenic.
Okay. Someone's asked if there's a role for oral trimethoprim as an antibiotic for acne.
Yeah, so oral trimethoprim certainly is not the first line of choice. Probably cotrimoxazole has been used. Yeah, and certainly when patients have an allergy to tetracycline, or they cannot tolerate tetracycline and they can't tolerate isotretinoin, then cotrimoxazole has been used. Yeah, in the treatment of acne. Okay. And in the cases that I've seen and the reports I've read, it is effective. But once again, I guess cotrimoxazole can also cause things like SJS or TENs, which is life-threatening skin conditions. So yeah, so sometimes you don't want to be prescribing that all the time. But certainly it's not first line. It's not indicated as a first line treatment.
No. But interesting to know that it is an option if you're working out of other things. Are there any other good topical retinoids? Someone's mentioned the ordinary grain active retinoid 2%, which has received good feedback from patients. What are your thoughts on?
I haven't really read any studies about that, but I think retinoids is retinoids. It's just in different chemical structures and bonds and different percentage. So as long as it's not causing too much of an irritation, then certainly, yeah.
Okay. And are there any funded options for an LHA?
No, not to my knowledge. Yeah, unfortunately.
Okay. How long can adapalene be used? Adapalene, sorry.
Adapalene has been shown it's safe long term, as long as patients are not breastfeeding or pregnant, or then it doesn't actually alter long term, doesn't have a significant alteration in the skin barrier function. Okay.
You do have a few questions that are slightly off the topic of acne.
Okay.
And slightly on the topic of rosacea, which is going to be a topic I think we're going to try and do another webinar on.
Yes,
So
absolutely.
I'll just try and get through all the acne related ones, and then we'll touch base on the rosacea if we have time.
Yeah.
Any further suggestions in particular for the maskne, or would you just sort of say follow the sort of guidelines in terms of mild, moderate, severe?
Yeah, I think with maskne, it's definitely, we have to choose the right fabric of the actual mask, because that is actually quite important, because lots of the fabric mask it's quite occlusive, and therefore you're rebreathing a lot of your humidity back, and this is such a humid environment. So certainly I think choosing mask is the first one, and then if their job allows, then certainly I would say frequently take their mask off and try and gently dab their face in the lower part of their face, and then put the mask back on. Definitely they need to wash their mask frequently, or otherwise just use the disposable ones.
Okay. I mean, they do say those surgical grade masks are a little bit better anyway. So
Correct.
not so good for the environment, unfortunately.
Right.
Any diet advice or anything that you would recommend people avoiding, like dairy?
Yeah, so certainly I just say avoid all the high GI load food, and certainly try and avoid a lot of refined sugars, and fast food, try and avoid it. Yeah.
Okay.
Just general advice.
Everyone's asking now about what was that sunscreen that you mentioned?
Oh, yes, it's the La Roche-Posay Invisible Fluid, the Anthelios SPF 50.
Lovely. And do you have a daily moisturizer that you recommend for people with acne as well?
Yeah, so when I prescribe isotretinoin, so if they're on isotretinoin, then I do recommend the Effaclar H or the Cetaphil Acne Prong moisturizer.
Okay.
So not the Effaclar Gel though, because Gel is the maintenance. But if you're already on isotretinoin and skin is very dry, then I'll recommend the H. Yeah.
Okay. And in terms of surgical treatments for scarring, where can people access those apart from a dermatologist? Is there places where people can get chemical peels safely, or would you recommend always going to a dermatologist for things like that?
I think possibly have a consultation with the dermatologist, just because it just really depends on the actual scar. Because if it's very, very superficial, then yeah, they can go to a beauty therapist or somebody to have mild chemical peel. That's absolutely fine. However, when the scar is deeper, the superficial or mild chemical peel is not going to actually work. You need medium strength. So then it's much better if you're under a guidance from a dermatologist so that you don't get the associated adverse potential side effects.
Yeah, okay. Would doxycycline use negate the gut flora protection of prebiotics and probiotics? So if someone's on a prolonged dose of doxycycline, how would we protect their gut flora?
Yeah. So certainly, and I think when we were used to be able to go to conferences, so in the AAD, so the American Academy of Dermatology, that was quite a hot topic in 2019, and in fact, there's been, which I haven't seen anything being published yet, but a lot of work has been put into to look at isotretinoin's effect on the gut flora. So not just doxycycline, because I think there's been some preliminary work done to look at isotretinoin's effect on gut flora, and I believe there is. So yeah, so it's all, the whole concept of microbiome is all still quite new, and I don't think we quite know how to combat that yet. So certainly it can negate the effect of pro and prebiotics, but I just say take them both.
Yeah, I mean, it's not doing any harm really. So if it protects, it protects. So we are running out of time. So I'll just ask a couple more questions. So I do apologize to everyone who's asked questions about things other than acne, and hopefully we'll be able to provide a webinar in the future regarding rosacea. And please give us any advice if there are any others, dermatology or skin conditions that you would like a webinar on. Just a last couple. So how to treat pregnancy acne, whether it's on the back or the bottom of the skin, and infant acne as well.
Yeah, so I think in pregnancy is certainly tricky. So I think I would just stick with a macrolide and use topical clindamycin, unfortunately. And usually after you talk to people, then people generally say, oh, actually, I'd rather not have any treatment, just because any medication can potentially, people want to stay natural. In terms of infant acne, usually is self-resolving. So we generally just stick with topical treatment, definitely no oral treatment, and just good face wash, and light moisturizer. It's the basics, and then stick with topical treatment.
Okay. And just quickly, how slowly do you taper your isotretinoin?
Yeah, so I do taper it rather slowly. So after they've achieved clearance, so you stay on the same dose for 3 months, and then I will then reduce it. If they are on 20, I'll reduce it to 10, and then 10 for 3 months, and then reduce it once again to every other day, and then twice a week, and then stop. Okay,
so you wouldn't go 5 milligrams daily, you'd go, and you would do it in 3 monthly sort of sections?
Yeah.
Okay. Interesting. And then so you go every other day and then no more.
Yeah. And then just give them topical treatment for maintenance. Yeah.
Yeah. Okay. And in terms of adapalene, do we prescribe adapalene before the oral doxycycline, or would you do it at the same time? Or
so if it's moderate acne, I'll do it at the same time. Okay. If it's mild, I generally just prescribe topical by itself. And then reviewing 6 weeks. Yeah. If there's absolutely no effect, no improvement, then add in the oral treatment.
Okay, cool. Look, I think that's all we have time for today, and I'm really sorry we didn't get through everybody's questions, but as I say, please give us your feedback and for future webinars, because we'd really like to hear from you. Peggy, that was such an excellent talk, and I really appreciate you answering the many questions that we had.
No worries.
I really appreciate your time tonight. So, and thank you for everyone so much for joining us tonight. Also just want to say thank you again to our sponsors tonight, La Roche-Posay. They have some sample, they're able to provide samples to healthcare professionals and for patients to offer a risk-free trial. I've popped the email for them in the chat section of this webinar, and so and that will be part of the resources that we send out tomorrow. So please do touch base with them if you want any samples. But thank you again, everyone, and I hope everyone has a lovely night and stay safe out there.